the main focus of my presentation is to say something about what this concept brings us at the bedside as a practical rule. We have shown this relationship between driving pressure and mortality, and pay attention that when I'm discussing driving pressure, I'm talking about the measurement that we get with zero flow conditions, and very important, we cannot use long inspiratory pauses, because otherwise, if you take a long inspiratory pause, or if you have a slow flow, your driving pressure is going to be lower because of viscoelasticity of the lung. So typically, we are talking about a short inspiratory pause of just a half a second. And then you capture a little bit of the dynamic component that is applied to the tissue. Okay. So in experiments in animals over 48 hours, it's very easy to produce ventilator-induced lung injury, so you have lungs like liver in this, and then you start to protect them, applying two different types of mechanical ventilation. I can have exactly the same tidal volume, but manipulating with PEEP, I can have a lower or high driving pressure for the same tidal volume. And then it's easy to show that a lower driving pressure produces a much better result. And not only this, I can, after 48 hours, I can have a PET scan, and I can show that I have much less inflammation, as shown here, when we reduce the driving pressure for the same tidal volume. And the damage, initial damage of these lungs were the same. So this is just one illustration. So in this experiment, we could get a difference of 8 centimeters of water of driving pressure for the same tidal volume and same severity of disease. And one important thing that we are now doing lots of research on this is that this driving pressure per cycle is associated with a big difference in lung fibrosis. And then this has been repeatedly demonstrated, and not only in animals, but in patients. So we took some patients after 6 months of ARDS. They are survivors, and most of these patients, they had some degree of lung fibrosis, and there was a very straightforward relationship between driving pressure and vital capacity after 6 months. And not only this, those ones that had lower driving pressure, arbitrarily chosen as 13, because this was the median value, they didn't have lung fibrosis developing according to samples in the blood and samples in the BAL. But then when driving pressure was higher, they developed lung fibrosis assessed by raw collagen type 3, and this correlated with the vital capacity 6 months later. So it looks like the interstitial fibroblasts, they are sensitive to the driving pressure. And there was no correlation with tidal volume, no correlation with other ventilatory parameters. Okay, then we have this concept of power proposed by Luciano. And basically, the power concept is based on this mathematical formulation that the whole energy that you were applied to the lung in one respiratory cycle is defined by the pressure volume area. Airway pressure, volume, and then this whole area would be related to the energy that the ventilator, sorry, I missed the presentation. Hello? I missed the presentation. Back. skip a few slides to keep the time frame. This is something very important. So from the experimental perspective, driving pressure was the most important parameter related to inflammation and lung fibrosis. But then we went on trying to see how we can compromise this at the bedside. So for instance, if we have a, let me just, okay. And then I was discussing this, that the formula of power is embracing multiple components. For instance, although this is the trajectory of tidal volume, because you're at a certain peak level, so this is what is going on with airway pressures. You have the resistive component shown here, which I don't believe that should be related to damage to the lung, because this is applied to endotracheal tube and airways. You have the dynamic component and the static component related to PEEP. For me, this is the most difficult part to understand, because this static component, and forget this green area, because this is just when the initial settings of the ventilator. This static area is a kind of potential energy. So although power computations are taking into account this whole area, why we should include this? Because this is elastic energies, potential energy is not absorbed by the parameter. And so I believe that we should compute only this, but let's take what happens when we compute only this and the different components of power in human beings. Pay attention that all these power equations are based on the concept that the lung is a machine, but in fact it's a biological system, and everything could be different because it's non-linear. And as John mentioned, some investigators like Proti have already proposed that the most important thing is to consider the dissipated energy, not the delivered one applied by the ventilator. And the dissipated energy is just this tiny area, which is very difficult to calculate at the bedside. This would make much more sense for me if we were capable of measuring this. So this tiny area is the hysteresis area, and interesting enough, I found very old papers, for instance from Hildebrandt, showing that the hysteresis area is just this tiny component during tidal graphs, and this is related to the dissipation of energy. Look at this. There is a very good correlation, and this is the best correlation of hysteresis area or the dissipated energy and driving pressure. No good correlation with tidal volume or other parameters. So let's check these in patients, and now we have a total sample of almost 5,000 patients. And then we check each component that you set on the ventilator, and all these patients, they had enough parameters to calculate power. And we check first the individual parameters. So which is the association between these parameters and the outcome? As I was expecting, so only driving pressure and frequency, they were related to the outcome. Let's summarize all these parameters into the power concept. So we calculated according to the formula, and let's check the association of power with outcome. Okay, there is some correlation, much weaker than driving pressure, but this is univariate analysis. Let's do multivariate analysis. You see, the power disappears. What does it mean? Is that at the bedside, this computation is not bringing us any information. If you just compute driving pressure and respiratory rate, you have all the picture in your mind. And then you can understand if a certain strategy is going to be protective or damaging. Okay, I'm skipping this, and to the sake of the time, and then I'm going to go to this very important clinical question. and then I think I'm going to make my case, because, okay, I have just demonstrated that the power computation is not bringing us additional information if you have already the computation of driving pressure and respiratory rate. But then there is this very important question. Is it worth to decrease driving pressure or tidal volume by 20% at the expense of increasing the respiratory rate to keep the same PCO2 levels? And I think this is very important at the bedside, because we have to take these kind of decisions all the time. So we did this study in pigs. So, for instance, we decreased tidal volume and increased respiratory rate to have the same PCO2 levels in both conditions. But now we increase the respiratory rate a lot, and there is some concern that this is going to increase power. And indeed, this is true, because power is double here. But let's see what animal is going to have more injury. So these are the two groups. So one group with high driving pressure along the time. So pay attention that this is 24 hours experiment. And another group with low driving pressure, but a much higher respiratory rate and higher power. What happens? First day, second day. So there is an increased inflammation in this animal. The driving pressure was high, but power was low. So this animal was not protected. Okay? Now let's take the other group of animals, the randomized arm. This is the baseline injury, and this is after 24 hours. So inflammation decreased. Why? Because driving pressure was low, despite the fact that power was very high. So power is introducing noise in our information at the bedside, is leading us to a wrong conclusion here. This is even more striking. I have two animals with the same power, and I look at the second day. This animal had persisting inflammation, and this animal decreased a lot the inflammation. Why? Because driving pressure was lower. So I think when we compute power, we miss this priority of driving pressure and respiratory rate over other parameters. So this is my case. So I think power computation brings us some confusion, because it's not giving us clinical information. And then the answer to this question is yes, we should decrease driving pressure and increase respiratory rate despite the increase in power. And I think this information is not bringing us any new information. Thank you very much.